My name is Jeremy Strader. This is my presentation on frailty and osteoporosis. This is the geriatric syndrome presentation for nursing 5013. This slide details the contents of the slide presentation as they are presented in a grading rubric, as well as provides clarity for the flow of the presentation. Side note, this presentation is not based on a particular patient, but rather the syndrome itself. Therefore, some of the subjective and objective data will be what is expected during an assessment and not details of a previous patient experience. Allergies, current medications, and immunizations have been omitted for those reasons. I chose frailty and osteoporosis for two reasons. One, I remember the calcium lecture in my original A&P class when I started my prerequisites for the nursing program at Walter State. The A&P lecture was on the prevention of osteoporosis and how it starts at an early age. The instructor had calcium candies and encouraged us all to buy them and start replacing calcium. Well, the next thing I remember is how expensive they were, and I was not about to spend that much money on candy. And two, my family members are nearing the age of really needing the lost or missing calcium, and if I can hone in on one syndrome that I can utilize both in practice and at home, this was it. So frailty is a medical syndrome that is difficult to define due to its complicated origin and standards of diagnosis. Frailty is not an actual diagnosis, nor is there an ICD-10 code, and therefore it is a syndrome rather than a disease process. Frailty is not a comorbidity or disability, but a factor for comorbidities and disabilities. Inclusion criteria is when three of the following are present: unintentional weight loss of 10 pounds or more in the last year, self-reported exhaustion, weakness based on grip strength, slow walking speed, and low physical activity. Reserves due to dysregulation of several physiological systems and is associated with poor outcomes such as disability, death, and hospitalization is another way to define frailty. In other words, frailty is the gradual decline in multiple body systems resulting in the patient being more susceptible to injuries due to falls, weakness, and overall health decline. There is one specific disease process, osteoporosis, that can significantly contribute to frailty. Osteoporosis is a skeletal disease characterized by a decrease in bone mass and deterioration of the bone tissue, resulting in fragile bones and an increased risk for fracture. In the background, the researchers and healthcare providers have recognized the importance of frailty and support attempts to prevent the syndrome, however, cannot come up with a universal definition and diagnostic criteria. With osteoporosis being one of the leading causes of frailty, it is important to be aware of signs and symptoms in order to initiate treatment or prevent furthering the condition. The significance of frailty is it's a common clinical syndrome in older adults that carries an increased risk for poor health outcomes, including falls, disability, hospitalization, and mortality. Osteoporosis is a silent disease because there are usually no signs or symptoms until a fracture occurs. It is significant for the nursing profession because we have to screen, identify those at risk, and treat patients before an accident happens. And statistically, from 2013 to 2015, 3,700 more hip fractures occurred than were expected and increased significantly compared to the past several years. In the United States, approximately 10 million people have osteoporosis, and an estimated 50% of women and 25% of men will experience an osteoporosis-related hip fracture in their lifetime. And based on one study, the overall prevalence of frailty in older adults aged 65 and older is 7 to 12%. Although this presentation is not based on a certain patient that is taking specific medications, it's just as important to know what medications can influence and or increase the risk of occurrence of osteoporosis, which can lead to frailty. Medications such as corticosteroids, thyroid hormones, anticonvulsants, anticoagulants, lithium, chemo agents, and acids and tetracyclines all place the patient at a higher risk for developing osteoporosis. Frailty prevention is difficult due to its nature. Weakness, the loss of muscle mass, and other physiological age-related changes occur due to several reasons. One of those reasons is the decrease in the patient's life space. A patient may not want to walk as much or as often within their home, or they may not go outside as often, and therefore they decrease their life space, resulting in a lack of exercise, which therefore results in a loss of muscle mass, increased weakness, and lower amounts of stamina. These ultimately increase the risks for the development of frailty. Osteoporosis prevention includes an array of modifiable and non-modifiable risk factors, and age-related changes are a huge factor, as well as intrinsic and extrinsic factors. There are too many contributing factors to list, however, I'll go over a few of them that include non-modifiable and modifiable. Medication, lifestyle, bad habits like smoking, drinking, physiological changes like the decreased production of estrogen in women, diet, comorbidities such as diabetes, rheumatoid arthritis, gastric surgery, and other factors such as race and gender play a factor. Other risk factors of the syndrome include a family history of osteoporosis, related fractures, low body weight, low physical activity, being white or of Asian race, and smoking. The typical patient presentation can be a challenge to identify. Since frailty can be difficult to identify and diagnose as a primary concern for the patient, the typical patient presentation may be difficult in the early stages. Being able to observe the patient's gait as they walk to the exam room is a great way to identify one of the inclusion criteria. Grip strength can be assessed as part of the physical exam, and weight loss can be reviewed in the chart. Asking about exhaustion and physical activity may be a good question for the significant other or spouse to see if they are able to provide their opinion of the patient's increased exhaustion or weakness, and they have a good outside view of the patient. A mental picture of advanced frailty is not all that difficult to picture. However, early frailty may not be easy to identify. Patients with osteoporosis may be asymptomatic, and it may only be discovered after a fall with injury. Presentation could or could not include acute hip, back, or other musculoskeletal pain, and upon exam the practitioner should inquire about a family and personal history of fractures, smoking, libido and impotency, loss of height, kyphosis, abnormal gait, dental history, breathing pattern, tenderness for palpation in the lower thoracic and upper lumbar region, and the distance between the rib cage and the anterior iliac crest. Reviewing the symptoms and pertinent negatives, as I just mentioned, there are several areas of the physical exam that will have to be reviewed. The breathing patterns, gait, and musculoskeletal pain should be assessed. The exam and review of symptoms will consist of a great head-to-toe assessment encompassing each system even as the patient walks into the room. A good history of the patient's activities at home will also need to be covered. Common complaints. These patients may or may not have a complaint of pain. They may present to the office for their annual checkup and be presumably healthy. Or as mentioned, they may have a complaint of back pain, hip, or leg pain. The practitioner may recognize the inclusion criteria during the clinical visit by paying attention to detail, observing the patient, and by the stories the patient tells during the visit. This could be normal due to the unknown syndrome that may be present but has not resulted in an injury at this time. However, the patient could have tachycardia or hypertension related to pain. A careful review of the patient's vital signs from previous visits compared to today's visit may reveal normal, but vital signs could be elevated for the patient. The patient's weight should be evaluated for changes to include a 10-pound or greater loss over the last year. Pertinent physical exam findings. Pertinent exam findings would correlate with a previously stated review of symptoms. The patient may have a negative exam in the beginning stages of osteoporosis or prior to any event, or the patient could have mid to lower back pain, hip pain that increases with weight bearing, and knee pain that causes an abnormal gait. The patient may have labored breathing or shortness of breath from walking to the exam room. Additional observation of thinning or reduced muscles can be important. In the winter months, having the patient get into a gown could prove beneficial in order to observe any obvious or gross changes in weight and overall body mass. And cachexia would be an important exam finding. It can be difficult due to its limited definition and inclusion criteria. Screening for contributing comorbidities would be important and could help identify factors contributing to frailty. The 2018 USPSTF statement recommends screening for osteoporosis with bone density testing in women 65 and older. Osteoporosis usually occurs in the weight-bearing joints such as the hip, spine, and wrist, resulting in an increased risk for fragility and fractures. Half of all postmenopausal women will have an osteoporosis-related fracture in their lifetime, and 25% will develop a vertebral deformity, and 15% will have a hip fracture. Radiological study and screening tools are somewhat limited to the recommended DEXA scan and the other BMD screening tools used for osteoporosis. There are other tools that can help predict if a patient will fall, have a fracture in the next 10 years, or need preventative treatment. One screening tool is clinical judgment. If the patient has multiple associated risk factors, including modifiable and non-modifiable factors, they may need additional testing in consideration for a BMD test and frailty. The USPSTF recommends screening patients with a bone measurement test to prevent osteoporosis-related injuries. The PRISMA 7 test is a 6-question questionnaire that helps identify whether or not a patient is indicative of being frail. A score of 3 or greater indicates frailty. The Tenet Balance Assessment Tool is used to assess the elderly patient's ability to complete several tasks with the goal to assess their likeliness of a fall. The test starts with a patient sitting in a chair that has no arms and progresses to walking. This tool can help the healthcare provider assess the probability of a fall that will result in injury. It is designed to use the clinical findings and risk factors of a patient to identify and estimate the 10-year probability of a major osteoporosis-related fracture. The Osteoporosis Self-Assessment Tool is a mathematical equation that uses the patient's age and weight to identify their risk level. Their body weight and age is used to identify if they're frail. The OST equation is weight in kilograms minus the age in years times 0.2. The simple calculated osteoporosis risk estimation, the SCORE, this test uses 6 factors to identify the level of risk the patient has for osteoporosis: age, weight, race, estrogen use, previous fracture, and rheumatoid arthritis. There are a few specific diagnostic tests to assess for frailty specifically based on its complex diagnostic requirements. Several diagnostic tests do exist for underlying comorbidities, but not specifically for frailty as a diagnosis. The bone mineral density test is one of the staple diagnostic tests completed for osteoporosis. The BMD can be done in several ways, including a DEXA scan, quantitative CT scan, and ultrasound. The USPSTF recommends screening for osteoporosis in women 65 and older with some type of bone mineral density test, but screening for men does not have sufficient supporting evidence. Lumbar x-rays can be helpful in some patients in order to identify vertebral fractures, and lab work that will need to be considered includes vitamin D and albumin levels due to their correlation with hyperparathyroidism and calcium, respectively. For frailty involves treating the underlying comorbidities that have led to the syndrome. Physical therapy with the goal of strengthening is one option. Education, encouragement, and examples of home exercises can help expand the patient's life space and therefore help with the overall strength and mobility. Physical activity as an intervention for frailty is an interesting and possibly positive way to reduce and prevent frailty. Treatment can be difficult due to the needs to address multiple dysregulated symptoms versus treating only one. Furthermore, evidence has been shown that only targeting one system has not been effective in preventing or reducing the rate of frailty. One modality to consider in frailty is the patient's diet and the lack of consumption of energy-based foods. Other components that contribute to frailty related to energy include sarcopenia, muscle weakness, altered glucose metabolism, and mitochondrial function. Treating osteoporosis will help reduce the impacts of this particular comorbidity, but is only one piece of the treatment consideration. Successfully addressing frailty will entail multiple modalities in order to address all the contributing factors. If the syndrome is advanced, rehabilitation or placement in a nursing home should be considered. Differential diagnosis that should be considered, however, they should be seen as contributing factors for the syndrome and not an actual differential diagnosis in itself. The following differential diagnoses should be considered: osteoporosis, failure to thrive, muscle weakness, other abnormalities of gait and mobility, abnormal weight loss, and low back pain. Ruling out each of the above differential diagnoses would be done with consideration of their accompanying comorbidities and the patient's overall clinical presentation. A patient could have one or more of the differentials. However, frailty would encompass multiple contributing factors that result in the patient's decreased mobility and function. These differentials would not necessarily be ruled out, but used to rule in the frailty syndrome. The final diagnosis would be determined based on the patient's clinical presentation, history, and evidence of the syndrome based on contributing factors and comorbidities. There are several challenges with this patient and the syndrome. The most important could be how to prevent injury and progression of the patient's other contributing factors. The family status and dynamic will need to be heavily considered at this time. Decisions will need to be made that will protect the patient from injury, ensure they are safe, and promote good nutrition and hygiene practices. This transition from being the patient's problem to being the family's challenge for the well-being of the patient. Essentially, the challenges will be greater than and possibly outnumber the answers and solutions. Would prove to be very beneficial for patients with this syndrome. Some areas have senior centers that host events in order to keep the elderly population busy and engaged versus sitting at home and being stagnant, depressed, or in danger of mobility depletion. Senior centers give the elderly population a place to socialize with others their age, participate in arts, crafts, and other activities to keep them moving and promote a healthy lifestyle. The local health department should be assessed for elderly programs in order to help keep the patient active as well, including increasing their life space and getting education on programs in the community. Church activities are beneficial to the patients because they help benefit their physical, mental, and spiritual health. A check into the patient's church would potentially help expand their life space as well, help them stay physically active, and reduce the chance of depression. Community centers offer activities for the elderly population, including low-impact water aerobics, bowling, and gym workouts that can all benefit the patient's muscle mass and help them continue with their mobility and increase their stamina. Educating the patient on multiple community resources will prove invaluable to maintain their activity level and promote interaction with others. These activities will also reduce the rate of sedentary lifestyles that can become comfortable after retirement, but lead to decline in health. Multidisciplinary health providers the frail patients will benefit from the collaboration with physical therapists, occupational therapists, and possibly home health services. The patient population will need specialized help and support that will keep them motivated in order to prevent muscle deterioration, falls, and the loss of bone health. Can increase the risk of frailty include smoking, obesity, minimizing the patient's life space, and sedentary lifestyles. It's difficult for the elderly population to stay motivated as they get older. It's also a challenge for people to make life-altering changes late in their life, such as quitting smoking, losing weight, or starting to walk and exercise. The challenges of getting old are not a fun experience, and this population will see the negative or positive results of their health behaviors over their lifespan come to fruition. Social determinants of health are different aspects of the community that the patient lives in and how it affects their range of health, functioning, and quality of life, outcomes, and risks. Are included in the environment where the patient lives, works, learns, plays, and worships. Examples of social determinants of health include access to healthcare services, exposure to crime, violence, and social disorder, public safety, and availability of resources they need to meet their daily needs. Frail patients may have challenges with all of these aspects depending on how early in the syndrome they address their contributing conditions. The sooner the patient addresses their needs, the better the outcome will be. Socioeconomic status. It's been concluded by the CDC and other reports that people with a lower socioeconomic status have an increased risk for cancer, smoking. They don't see their healthcare provider as often as they should. They often eat unhealthy foods and are more prone to detrimental health conditions. People with lower socioeconomic status are less likely to see their doctor due to the lack of insurance or the inability to pay for healthcare services, as well as they don't normally speak English. Legal or ethical issues. As the healthcare providers, we are supposed to have genuine concern and care for each one of our patients. It is important to understand the obligation and make the best decision possible for our patients to ensure they have the resources they need in order to live a healthy and productive life. Becoming a challenging syndrome that is gaining momentum within the healthcare industry. With its definition and diagnostic criteria being challenged and unclear, providers are having a difficult time addressing and diagnosing the problem. It is a problem, and through this project I have learned that contrary to my previous beliefs, frailty is not an actual diagnosis that can be managed or treated by a simplistic regimen of medication or therapy. Fragility is a very complicated and difficult syndrome, and it will continue to challenge professionals across the spectrum. Providers need to have the knowledge of comorbidities that contribute to the overall deterioration of the patient, but most importantly, have the courage and willingness to motivate them to do better and ensure they have the appropriate resources and specialists involved in their health care in order to provide the best possible outcome. The next two slides are the resources that I used for the information for my presentation. Apologize, it's a little longer than I expected. Hope you enjoyed the presentation. I definitely learned, and this was a beneficial project.